S.O.A.P framework helps to bring that together. So the subjective, what's your initial impression of the difficulty? And then the objective, what are the details? And can you write it down on paper? Can you document it? Because if someone's having enough difficulty where you're talking about remediation, you want to document this for their sake and for the process of remediation. And then once you have that, what is the problem? What's your assessment? What's your diagnosis of what's going on? And once you have that, then it's about developing your plan, implementing it, and making sure there's both follow-up and follow-through. Making sure that it resolves, or if it doesn't resolve, then what? Does it need additional remediation, or is the learner falling in that category of maybe they won't be able to practice independently, and maybe they really should be looking at a different career path? So how do we get the S and the O, the subjective and the objective? It's pretty much the ways you already said. Patient reports and surveys, 360 assessments, formal evaluations that you get, and then the roundtable part of it. You may have heard that there are some people in education evaluation that think the grades are inflated. And maybe they are, but we all make complex decisions every day, right? We deal with complex patients, so why would you think that we can't figure out how well a learner is doing? So we can, and we actually do it very well. However, in the background is we really don't want anybody to fail, right? You know, if we can help them. They're our colleagues, they're our future fellow physicians, and we really would like them to succeed. So part of the problem is we really do want them to succeed, and that's a good thing. And part of the problem is most of us somewhere had somebody give us feedback or evaluate us, and it wasn't very nice. It wasn't just that they were trying to help us out, they might have even been mean about it. And we don't want to do that to somebody else. And so we start to fall into this failure to fail, that we are failing to fail them because we don't want it to be bad for them. And that's understandable.
But that's not the reason. The reason we're not failing people is because it's too much work.
That is part of it too.
No, it's the main one. We
You
have
think?
horrible residents, and none of us here, including myself, the few times at the beginning when I started, when I started working here about 10 years ago, and I started to write tougher evaluation below average, I was getting called by everybody. It's a horrible waste of time. It's very uncomfortable with the when you see the resident all the time because they know you're the only one. Nobody else does it, and the truth of the matter is it takes way too much time to fail somebody. So frankly, we have a lot of people who should be failing that we're not doing.
Okay, so let's take a vote.
This is a very
well, I think this is important because if that's a big part of the problem, then really we should look at how can we help overcome that. So how many of you wouldn't fail a learner because it's too much work? Be honest. I'm not writing this down. Lisa's not raising his hand. All right, so that's at least half of you. Okay.
It depends how.
Yeah, it depends how bad. The only one we were able to expel here was the unfair. You remember, right? I mean, this is somebody who clearly, deserved to be. But there's a couple of others that would have, if not, I wouldn't have personally, wouldn't like them to take care of any family member of mine.
And that is the criteria. Would you want them to take care of your family member that you love?
It's not just the failing that we're talking about. It's any grade that you give less than 5, you need to write this explanation why you are giving them a 4.
And
so why should I be giving a 4?
People.
It's much easier to give them all 7s and 8s. It doesn't ask you anything more. So in the computerized evaluation, you can, and then you will be called in to say why you are giving them a less grade. So you have to document so that you can give them a warning. So you cannot, it's really a lot of work. Anything less than 5 is not acceptable. It says you can't do it. In a sense, because you have to write so much things. It's not failing at all. Even a suboptimal evaluation so that the resident can improve. Even a student, if a student has to improve, I say that student has to improve. So 4 is not a failing grade, but then I have to write this long so that the evaluation can look good.
I'm going to ask you 2 questions. I was going to ask you.
That's it.
Number 1 is, with the intern resident hour rules, I think most people are trained at a time where if you have an unstable patient in the ICU, you wouldn't go home for their stay. but now it's kind of like shifted. And would you, I mean, how do you, the guy who goes home because it's 4 o'clock, he's just following the rules, but to me, I'm giving a couple of demerits. I would expect, the old college spirit that he would, I don't know how you
Is it okay if I separate those two? So let's talk about the easy one first, work hour rules. So we're stuck with work hour rules, whether we think they are appropriate or not. But you're right, that is one of the concerns. So one of the concerns are handoffs, right? And we all know that the more times you hand off, the more likely there is to be a mistake. However, given the work hour rules, one of the things our learners have to learn how to do is to hand off well, so those mistakes don't happen. So I would say, try to turn it around and make it a valuable learning experience. But there's also that judgment piece, right, of how long do I stay and at what point do I hand this over? And you're right, for about 2/3 of us, we were trained back in the day where you would just stay. You would just stay until it was finished, done, or it reached a point where you really need to do a handoff because it wasn't going to be done. So we can't go back to that. So what I would say is part of what we need to be teaching our learners is then how do you hand this off well? Because now you can't stay forever or you're going to get in trouble, the program's going to get in trouble, and we don't want to handle it that way. So part of it is teaching them that, okay, if it's going to be finished in an hour, as best you can determine, if it looks like an hour from now it's going to be done, then okay, you stay for that. But if you really can't be sure that it's going to be done, then you need to do a handoff, but you need to do it well. And so that's what we're left with. I mean, I don't like them either, and I could spend the whole night talking about those, but I don't have any power to change them. So how do we make it work better until somebody comes up with a better model? Now let me finish the other question people had. So you are right. I would agree with you that it is much more work to fail somebody. And like you, I'm one of those faculty that if you're not doing 5 work, you're not getting a 5. If you're only doing 3 work, you're going to get a 3. But it means I have to put a lot more work in to that evaluation. However, that's why we're here. And it is more work, and it should be easier to do, but I would challenge you back with that. Is this somebody that you really want to be practicing independently? And I will also say that medical schools are doing their part. Okay, and I can't change all the medical schools. But Dr. Appentak and I can work hard at Chicago Medical School to influence our process so that we are catching medical students sooner, so that those that really shouldn't graduate don't, because that's the job of medical schools. But again, we are not all doing our job at the medical school level, so you are getting residents that probably shouldn't have graduated medical school, and now you're stuck with, they really shouldn't be practicing independently, now what do we do? And I don't have a 100% answer for you, but what I would say is essentially the responsibility falls back to all of us that are the educators to say, okay, it's more work, but we're going to do it because we have this huge responsibility. The advantage that you have, though, is you have this whole set of colleagues who work together. So maybe that's a worthwhile project in the sense of you all devising a system that has adequate documentation so that you can actually show that the resident, the student, isn't progressing in spite of appropriate feedback and remediation plans, and really should not graduate. So coming up with a system together that you agree to that has adequate documentation and at the same time decreases a bit the level of work so that you really can say, this person shouldn't graduate. They shouldn't be practicing independently. And that's hard.
How do we make the transition between the resident knowing that they have a very different schedule to becoming an attending and having to stay? Because that's not going to be ingrained in their brain. They're going to want to leave at 4 o'clock.
So does anybody know what the predictions are about that? I'm sorry?
They're all going to become shift workers.
Yeah. The prediction is they will practice different than us, than most of us practice. So it is going to change. because you're right, they're going through a learning system where it's basically shift work. And so they're going to choose a practice model that does that. And I don't know that that's good or bad, to be honest. I mean, it's a little hard for me because I'm going, this isn't the way I do it. But if we go back to, it's really about the patients. As long as the practice model is going to ensure the patients get the care they need, then it's okay. But it's going to be different. The prediction is the practice model will become different. So those of us that are in the over 40 crowd, when you're 75 and you come to the hospital, it's going to be so different.
I wonder think about something. We have ordinance CMS students here.
Yes, you do. You have a lot of students.
Should we hold everybody the same standard?
Oh, that's a good question. Excellent question.
I mean, because there's a lot of, the other students, there's a lot more variation in skill sets.
Correct. We're going to get to that in a little bit. I would say the basic answer is yes. However, it goes back to the setting the expectation. So you really do have to look at, for each group, each student, each school that comes for that clerkship, what are their goals and objectives? So what are the goals and objectives for that clerkship or that rotation that they expect you to achieve? And that's your standard that determines how they're evaluated. However, overall, it really should be pretty similar.
Going back to your point, I don't want to get off topic, but you just waved a red flag in front of the school. As a aging baby boomer myself, I don't want my care to be rendered by a shift worker who doesn't know and I do think, and I think there's no speaking for any of the people in the room, particularly those of us who have a few gray hairs or no hair, I do think the practice of medicine from the Asian viewpoint is going to lack something. It's going to lack a lot. And we can say these are the rules, et cetera, and basically it's putting lipstick on the page. Because this is a system designed for doctors. I'm sorry, I go along with the regulations too. We just had our survey. We're in pretty good compliance. It doesn't mean I think they're right. And in a group of faculty, I'm not going to say it. I'm saying it is. But this is not the way to practice medicine. This is not the way to treat patients.
And I would agree with you. So I continue to say our hope is in primary care. So it really is going to be general internists, family physicians, general pediatricians. And so what I tell everybody is you need to have your primary care physician or other health professional that knows you. That is your security through all of this. And that is focusing on prevention. So hopefully you never have to end up in the hospital. But if you do, they know you. And even though they may not be the person taking care of you in the hospital, they can communicate with and do everything possible to make the shift worker communicate with them so that you do get that care you need. So I would say the piece that will hopefully hold it all together is primary care. If you don't have that, I never really. So I did change that. Oh, okay. So assessment, categorizing the cause, and I liked this, and this is actually taken from the clerkship director's manual. Am I getting that right, Alicia? And their way, and I thought it was a very good way of putting it into pockets and lumps and categories that then from that you could come up with more detail for your remediation plan. So is it cognitive? Is it knowledge, skill, reasoning, critical thinking, those pieces that are really completely cognitive? And in some ways the easiest to remediate. If you don't know enough, you can read more. Reasoning, you could argue, depending on where they are with their reasoning abilities. There are some folks that just will never reason like a physician. But for most of them, most of our learners, we really can work with them for appropriate reasoning. And then the non-cognitive. So is it behavioral? Is it really a behavioral problem? Is it professionalism? Is it attitude? Is there something more serious like substance abuse or mental health, depression? Can be a biggie, right, that completely changes people's ability to function. You can't organize, you can't sleep, or you sleep too much, you really can't get your work done. And those would probably be the two biggest categories that you come down to. Disabilities, usually by the time they get to the 3rd and 4th year of medical school and residency, if they have a physical disability, that's usually been identified by that point in time. But you might, on some of the more technical things, like if a medical student has a tremor that interrupts or impairs their ability to be able to do surgery or procedural skills, that may not show up till 3rd year, until they're actually trying to do those things. So you may see it at that level. But those things tend to show up pretty early on. What about the learning disabilities? When do they show up?
Under stress.
Well, what type of stress?
New information. New information.
And new information and amount, right? So we're all pretty bright. I mean, if you compare us to the average person, you know, in the world kind of thing, we're in that brighter category. So these, our learners are very bright, intelligent people. They've been able to compensate. So, but at some point, right, for all of us, you reach the point where because of the load, whether it's new information, whether it's workload, that you can no longer compensate. So sometimes a learning disability really doesn't show up until they're a resident. And so to be on the lookout for that, is it really a learning disability and then that needs assessment?
I would disagree. Well, I'm just going by my experience. In my experience, pre-med was much higher than med school and much more stressful because you've got to be in, I don't know what it is, up to 10, 20%. And once you're in the club, you're in the club, you know, and you don't have that stress anymore. Am I going to get in or not? Because that's how I found it.
That's true. The things related to learning amounts of information tend to show up in the first 2 years. But the stressors are different. So you may have been able to compensate by just studying more in the first 2 years. But now, when you actually have to pull it together, or what happens on rounds, right? You round, you identify areas where the students, residents need to gather more information, and usually you expect them to come back with it later that day. So that's a pretty quick turnaround, right? Plus carry out whatever their other tasks are, but you're going to get together again and review some things about the patients. You expect them to have answers. So the turnaround time is much quicker when we're in real life patient care compared to the first 2 years. So there may be some things that actually don't show up until later. And then systems issues. You know, is it really just workload? And we can do some things to adjust that. Are there other personal stressors? Are they a new parent? Is someone ill in the family? It may not be them, it could be somebody else. And then there's certainly the cultural adjustment. That I actually think it's much harder culturally to immigrate to the United States than it is if you grew up in the United States and you've immigrated somewhere else. Just think it out. I think we're crazy here, personally.
We do have a bit of a pervasive cultural issue here, especially with our male foreign medical grads and the way sometimes they treat the nurses, which is sometimes just not appropriate because they come from countries where there's a big difference and they think they can just bark over the grad. That's not the way it works.
Yeah, it doesn't work so well here.
Yeah. So, but we have, at least in cardiology fellows, almost all of them have the same problems.
So what do you do? So it sounds like that's fairly pervasive. There's enough of it that it's not just one or two. What do you do to help them enculturate to how you have to interact here?
Yeah, this is actually one of our improvement plans. We've noticed a cultural mismatch between our residents and our patients, which are entirely obvious. We're doing things including resident role-playing exercises, and we're in talks with a commercial firm, Iowa, that does getting executives ready to go into other cultures to come in and do training.
Okay. Oh, that's a really good idea.
For our residents.
That's a really good idea. We can talk about it. That's a great idea. But yes, really, that's exactly. You really need to do a very specific, targeted, educational, cultural education process. And it's going to take more than one intervention to do that. But it comes back to that patient care part, that if you intend to practice here, then you have to learn how to interact in a way that patients find acceptable and productive, that the nursing staff, your colleagues, everybody you work with, so regardless of what you believe, regardless of what culture you come from, you have to learn to interact in a way that's going to result in good patient outcomes.
It's
So, yeah.
the fellow's judgment, and that means the residency. I think it would be more for a character issue or a personal issue rather than culture, because it's already 4 years in the system.
That's an excellent point. So if you're seeing it in the fellows, you probably want to look at it and say, is there something more than just culture? Or how did they get through residency and successfully?
Well, again, it goes back to the fact that maybe we don't give them enough feedback about those kind of issues. Because sometimes, I don't know if they don't do it anymore, maybe they don't do it when they're in front of us, but, and there's maybe a character issue too as well. These are very grown-up people, yes, for sure.
Right. And so I would say yes, at the fellow level, you really want to examine and try to determine, is it just it's cultural and they need further remediation, or is there something else going on? Is there an attitudinal issue? Is there a behavioral issue? Is there a personality disorder? Right? So we all have some, we all have some degree of personality disorder, right? Yeah, we're all laughing, yes. Guess what mine is. But anyway, when it reaches the point where it's disrupting relationships and work, then now it's a diagnosis and a problem. So that would be the other thing to think about with some of these folks. Is it more than just culture? Is it really personality disorder? Is there something else going on that needs addressed? And those are harder to fix. So hopefully this gives you a scheme to kind of categorize it. What are the ones that are difficult to manage? I think personality disorders are one. Yeah, I think the non-cognitive kinds of things. Substance abuse, depression not so much, right? Because you can actually manage and treat that pretty easily and pretty well. But attitudinal issues can be difficult. Other ones.
Personality.
Yeah, personality disorders.
Cultural?
The cultural can be. And so it probably depends on the exact pieces of the cultural issues. And the things you're talking about with how you, if you're a male, and how you treat women and how you interact with them, that can be very difficult. There may be other pieces of culture that are easier. So the piece about what's expected in your interpersonal interactions, so the things about eye contact, the things about how you encourage and respond positively, non-verbally. Those may be easier things for somebody to learn and not as difficult.
But then I think where, in my mind, we can trickle down to one very important concept that so far I haven't heard being mentioned, empathy. Because if you have empathy, you're going to overcome the lack of cultural adaptability, your personality disorder, and the moment you're in front of the patient, you're going to leave all those negatives at the door, if you have enough empathy.
What do others think?
Well, I think empathy counts for a lot, but you still have to have the skills. You have to know how to talk to people. You might be empathetic as anything, but if you're a total jerk in how you address people, it's still not going to work.
But you're jerking enough at empathy.
Well, I've seen some people who are incredibly blunt,
Right.
oblivious. They're empathetic, they care, but they miss clues, they say horrible, hurtful things, and they don't realize it.
Yeah, I would agree, actually. So that's why I'm challenging the empathy thing. Empathy's a feeling, right? And so you really can, without naming names, I have family members who I know them well enough, and I know that they truly care about the people that they interact with. But if you came and watched some of their interactions, you would never think they cared because of what they say and how they say it. But inside, I know they do because I really know them very well. So I think you can have empathy, but yeah, still not have the skill set about how to interact. The empathy will help you. It'll get you further along, but you still have to have the skill set at some point. Somebody, I think, alluded to sort of the integrity, dishonesty part about not showing up when you know you need to be there, not doing the work that you said you would do, part of it. I think that is a very difficult one because it's a value. It's a cultural value. And if you don't value integrity, if you don't value truthfulness and accuracy, then it's a hard process to
That's
teach
also
them.
the easiest to document, especially that night. They don't show up on time, and that's all very easy to.
Right, yeah, exactly. It's much easier to document. Hard to remediate, but easy to document. The manipulative, the folks that are truly manipulative. It's not just they didn't know, they really are being manipulative. The substance abuse, because it can be hard to diagnose and hard to treat. Although I was reading something I thought was really interesting, that physicians have a better response rate to interventions around recovery from substance abuse. And they think it's because the stakes are so high for us, right? That if you don't complete the recovery program and stay in recovery, you're going to lose your license. And then you can't practice, and then you can't do the things you were trained to do. So the stakes are so high. I mean, it's still difficult, but better than the average. And then we talked about the attitude. Okay, so what's easy? What's not difficult to manage?
No.
Yeah, knowledge.
Some of the reasoning too, you can go out.
Right, a lot of the reasoning you can, right? You can teach them how to reason like a physician. You can teach them how to put together the pieces of information and come up with a diagnosis and come up with a management plan.
The cultural differences, I think, can be overcome to some extent.
Yeah, I think most of them can. Again, as long as the person is willing. And if their goal is to practice medicine in the United States, that's usually a pretty big motivator to say, okay, I understand. May not be the way I've conducted my life, but I understand that I need to change this if I'm going to be successful here. Yeah. So I think you're going to see it most of the time. So the fund of knowledge, technical skills. Now that said, you know, there are people that are technically skill oriented and there's people that aren't. So for the most part, the technical skills can be taught. The sort of overeager student, the learner that's really, I mean, they're excited. They're excited. They're overeager. You can work with them as long as they have the other skill set. If it's just organizational skills, you can teach people how to do that. How to dress, how to really interact with people appropriately. You can teach some of that. Okay, so the bottom line is all of these things can and are detrimental to patient care, so that's our motivator for filling out the papers, doing the reports, and going through the process that can be difficult to say, this learner really needs help. So how do you put a plan together? And certainly realizing that the specifics of your plan are going to depend on what the problem is, and some other specifics about the learner. Remember that shared responsibility part. The learner should be involved in the plan. Now, it's not a negotiation, but they need to be involved in determining the details of the plan, and some of what the timeline is going to be, what are some of the benchmarks going to be along the way. They should definitely be involved in it because the plan is for them, not you. The same things that we talked about with any learning experience, having well-described objectives and expectations. So at the beginning, you determine what are the objectives for this remediation, what's expected at the end of it, what's expected in the middle, having that timeline with benchmarks all along the way. What are the specific interventions that are going to happen? So if it's knowledge, what are the areas of knowledge? What sorts of reading, learning needs to happen? What are you going to do to make sure that they actually retain it and continue to build their knowledge and don't just stop after the remediation plan is over? Frequent reassessment. We say that all the time in learning, but in these situations, you really want frequent reassessment and feedback going on. And again, the learner can be responsible. So if the faculty this week didn't give you feedback, it would be your job to go to them and ask for it. So getting them involved in this process, because again, it's about them. You do want to document it. If you're really concerned that this has been confrontational, that the learner is very resistant, then it may be very worthwhile to have a witness present as you're defining the plan and have somebody in addition to you and the learner sign off on it. And then that it really does resolve, or if it doesn't resolve, then what are you going to do about it? And again, not a negotiation, it's a plan. So here's some elements. This is not all inclusive by any stretch, but some ideas to give you that if it's cognitive, it will be individualized, hopefully, about what are the areas of learning that they need to work on. What's their process for retaining it? and continuing to show that they're progressing in their knowledge. If it's non-cognitive, if it's a fairly straightforward behavior issue, you can actually apply the behavior change model that we use for patients in behavior change. So you can use that with it. You might have to use confrontation techniques, and I'll outline those. Has anybody heard of those before, confrontation techniques? No? I think when I describe them, you're going to say, oh yeah, I know what that is. If there's substance abuse, obviously a substance abuse program. And are you aware that usually state medical societies have, or the state licensing board usually has those, or a program that they approve? So most states have that connected to their licensing board, so that if you really identify someone who has a substance abuse program, you want them to be, a substance abuse problem, you want them to be in that program. A mental health evaluation, obviously, if you think it's a mental health issue, and then follow-up for it. Disabilities, reasonable accommodations, and there's the whole ABA description of what's reasonable for medical education, actually. And the AANC, and I'm going to think the ACGME also has a description of what are those reasonable accommodations. And if you really think it's a learning disability, having them formally tested for that, because most of those are things that can be remediated and methods taught to accommodate. And then system issues, which in some level are the easiest. Time management, are there other social supports that can be put in place if it's really coming around social responsibilities? We talked about the culture part. Don't forget about the language, right? It's one thing to be able to speak English. It's a whole other thing to be able to really understand it. That's a pretty high level of proficiency. So the learners where they've recently immigrated to the United States, it may be that there's a piece of English language that's part of the barrier for them. And so providing that support for them to go through a program that will really bring up their language proficiency. And the whole, medical English versus everyday English, you may be able to carry on a basic conversation well, but can you really do medical English as a whole other level of proficiency? All right, and emphasize that professional development piece. And I think someone said that very early on. This is about developing professionals, and that's really the goal. That's what we're trying to do, and that's what the learner needs to understand, that this is about developing them into a successful professional. It's not about punishment. All right, confrontation techniques. This is basically a summary, and it comes from Thomas Proctor, and I know it's 1988, but it's still relative. So when you really have to confront somebody, so this is the person, it can be a patient, it can be your colleague, it can be your child, your spouse, your learner. Same basic techniques of identifying and clarifying what the issue is, what's the difference, and try not to talk, unless you, sometimes there truly is right and wrong, and then it's appropriate to talk about right and wrong. But really recognizing that we disagree. You and I disagree, however, this is what is going to happen. Because this is what needs to happen for your development and for patient care. Letting them know that there's a problem. And sometimes we try to be too nice, and that's part of the challenge in that identifying the problem early, right? We kind of think, oh, they're just a fourth-year medical student, it's going to be okay, we don't have to get too worked up about this. But we really do want to be direct and say the problem is that the way you interact with families and patients is not appropriate, and it's bad for patient care. Really trying to diffuse the anger. So expect the other person's going to get angry. They're going to get upset. They're not going to be happy. You are telling them that they are not being successful, and they want to be successful. So expect they're going to be angry, but remember, it's really not about you. Most of the time, it's their frustration that they're not performing the way they hope to perform. They're disappointed in themselves. They're frustrated with the situation. It's not really you, even though the anger may be coming at you. So if you can kind of remember those three things, it helps you to keep it all level and keep it on course and not get distracted by their anger and their rebuttal.